It's a difficult question since we don't have evidence. However, I have to tell you my practice and a summary of evidence. So we have several observational studies, also from Asia, Korea, telling that the kissing in the left main might be of benefit. However, no decisive evidence for that. So if you do not do routine kissing, no one can tell you anything since there is no evidence pressure. However, in younger patients, I tend to do it routinely for the reasons that you mentioned, future interventions, but also there is another mechanical reason for it, and that is centralization of the carina. If you do not do kissing, you're never going to centralize the stent struts over the carina in the center, and fluid mechanics have been shown to be better with the carina in the center. Now, this may not play a huge role in non-left main bifurcations, but for a young patient with the left main disease, I tend to do the kissing almost routinely.
Kissing, then pot.
Exactly, finish with pot.
So you say that it is not, we should do it routinely, but it is not a penalty if you don't do it.
Exactly. That's exactly how it stands at the moment. And my practice is that ACS patients, especially elderly ACS patients, I would not do it. I would just do pot for a provisional, of course, strategy, given that the ostium is okay of the circumflex. But in elective younger patients, I would practically do it 100%.
If I can make a short comment, from bench testing, there is a problem that sometimes you don't pick the distal strut. So from Japanese trials, there is this risk. If you don't take the distal strut, it's not of a benefit that you may expect. But I can understand that for young patients, for patients having trouble in the circumflex, you have to do it properly, a proper kissing and pot after that.
There are many things you can do wrong with a kiss in real life and also in bifurcations. The problem is that it's not only the distal cell. The problem is abluminal wiring. As I said, pot is not always perfect, and I will talk about it now. Pot is not always perfect, and if you only leave a millimeter of unopposed struts, your wire will tend to go there. So never force. With a kiss, you never force, because if there is a balloon that has problems getting into the circumflex, the reflex that I have is change the wire position. And I tend never to take small balloons. I take the same NC balloon which I will do the kissing to go through the struts. If it doesn't go, I don't force it, change the wire position. But for all that, imaging is very, very useful, and this is why I will now tell you maybe a few points about how I see its role in bifurcation PCI today.
You use already amount of the 5 minutes that you have available. So go quickly.
I'll be very quick. The first thing I'll do, I'll slightly change the title from how to why. So I think that it's more appropriate maybe in those 5 minutes to address the question, why imaging-guided PCI today? And not be very exhaustive with how. So this is a timeline of how, in my humblest opinion, I see the evolution of bifurcation PCI. So 1984, and this was the team of Grunzing, Bernie Meyer published this. In 1984 was the first kissing balloon angioplasty. So basically a few years after the first procedure, there was already a kissing. Why? Because the side branches were the problem from the very start. So 1984, I would say, starts the evolution of bifurcation PCI, and you see the images are from the original article from the Swiss group, from Bernie Meyer. And then between 2004 and 2010, there was another important period, 6 randomized trials trying to answer whether 1 or 2 stents are better, and as a totality, they did point towards the answer that the 1 stent might be better. It evolved into a provisional strategy saying that you start with a philosophy that 1 stent will be enough and you change it to 2 stents only if you have to. This was the collective evidence from 6 randomized trials performed between 2004 and 2010. The caveat, all were performed in Europe. So when you look what happened next, was that you had to work on this 1 stent strategy, and look how late in the evolution of bifurcation PCI, even though it's very obvious, proximal optimization technique, firstly mentioned 2008. 2008 is the first mention of proximal optimization technique. We take it for granted. However, real-life studies show it that the rate of use of POT is at 40%. So we talk a lot about it, but we do not use it very often. 40% is the rate of POT in bifurcation PCI from a real-life registry called eUltimaster. Now, how did we know that? From bench testing. You see the images, and this is the 2008 mention of POT. It was noticed on bench testing that, of course, you have a huge gap in a large bifurcation proximal to the carina because the diameter is much larger. It seemed obvious, but it took us almost 20 years to try and convert this in practice. And then we come to Asia, to Xiaoliang Chen and his group, which showed that a new technique, which is a commitment to 2 stents from the outset, DK crush, is better than provisional. Now, of course, these are the trials coming only from his group. So in expert hands, in certain anatomies, and he himself says that for the majority of bifurcations, it is provisional. But if you have extensive disease, especially if it's very stenotic, the ostium, for example, of the circumflex and of the LAD, DK crush really is the technique that I also apply. Now, what do we have now? 2023, 2024, and on? I would say that 2 topics, in my, again, humblest opinion, will dominate the field of bifurcation PCI. One is imaging guidance, and second is DCBs. Let us see how DCBs will fare. We are going to concentrate on the imaging guidance, which I think is really a hot topic in bifurcation PCI, not only because of our practical learning points, but also because of the data. So October trial showed a year ago, basically, that if you perform imaging-guided bifurcation PCI, that is better than performing just based on angio. And you now have a class 1 recommendation by the ESC guidelines to use it for complex bifurcation PCI. Now the question is, what is complex bifurcation PCI? Is it 2 stents? Not necessarily. And that's going to be my main learning point. In the October trial, 65% did get 2 stents, but 35% were treated with 1 stent. So why would you have a benefit of imaging with 1 stent? Well, because what they had was kissing. So any time that you have to do a procedure on the side branch, any time that you have to recross the stent, this is where imaging can help. Mostly because of abluminal wiring, as you will see. So this is the main takeaway from the October trial. It's not about 2 stents. Anytime you attempt a procedure on the side branch, imaging will help you guide the procedure to the benefit of the patient. Now, in that trial, it was an extensive imaging protocol, and we can speak a lot about it. What I wanted to show you is that basically it amounts to the stent-wire interaction. So look, an image from the trial. Where is the wire? You see on the left-hand side of the slide, yellow arrow. The wire is outside of the stent contour. So if you want to pass it into the side branch, great, and then try with a balloon, and then try with another large balloon, and you're going to destroy the main vessel stent. This will drive the events, and this was very nicely shown in the trial. A quarter of patients will have events if you distort the stent. That's an important message. Now look on the longitudinal image. Let's trace the wire. It goes first into the stent contour, then outside of it and into the side branch. So you would never imagine that this 1 millimeter of malapposition will matter, but it does matter. And this is where I think imaging today is mandatory whenever you do anything in the side branch. Of course, if the side branch is important, you're not going to do that unless the side branch is important. So let me show you a case where this is demonstrated in our lab. This was a young patient with ACS and an occluded diagonal. So the attending physician does the stenting of the diagonal, which was the culprit vessel, and then calls me because he wanted me to help him with the OCT. So he says, I want to now do culotte. I think that this patient deserves culotte, but when do you think we should do the OCT? And I told him right away. And he says, why now? I'm just going to rewire the LAD and then finish the procedure as culotte. And my question to him is, how will you ever know, based on angio, that your wire is in a position that it needs to be for you to do culotte? So look what happened. Look at 2 images from this case. Basically, in the first run, the wire, which is where, from the LAD, where the probe is outside of the stent contour coming from the diagonal. So I told him, if you keep the wire here, the only thing you can do is DK crush. You need to rewire in a way that you're inside the protruding stent from the diagonal to do culotte. So he needed to rewire again do the OCT from the LAD, and now you see the probe of the OCT, which is in the LAD, inside the protruding white contour of the stent from the diagonal. Now he could do culotte, and he did culotte, and this was the final result on angio. And you see also, you can appreciate how the result looks on the pertinent cross-section imaging of the OCT. What I want to mention is the centralization of carina. You see in yellow the LAD, and then you see in blue the diagonal, and you see how these contours are roughly similar. And then you see at the point of confluence, there is no major malapposition. So you look at the centralization of the carina always when you have metal over it. That is important, we know from the flow dynamic studies. The second point, which is limited to bifurcation PCI, I think, is the continuity of the plaque across a bifurcation. And in the previous case, you could see how the plaque is continuous from the LAD into the left main. You see on this drawing, this will happen in 90% of the cases. So never attempt nailing of the ostium, I have to say, or very rarely, almost never. Why? Because 90% of the cases, plaque will go into the left main. If you have ostial circumflex, 67% of the cases, 2/3, will have a continuous plaque into the left main. This we know from IVA studies. If you place a stent, as you can see here in the drawing, you will be in the middle of the plaque. So you can say, well, no problem. Nothing major is going to happen because most of the plaque is treated. Most of the plaque was at the ostium. Let me show you a case what can happen. So we published this case actually last year, the images of the case, because I thought it was very educational. You can find it in neurointervention. So there was a primary PCI in proximal circumflex. You would say very routine. And you see on the moving image the final result of the primary PCI to proximal ostial circumflex. Very routine. What the operator did not know is what you see on the drawing. Of course, the plaque was continuous into the left main, and he and I and no one else can be sure that on a beating heart you can always be very precise. So what happened was that the stent was like that. He did not know that. So look at the epilogue. So a year later, a patient comes to me with a positive stress test in the anterior wall. So why would the patient have anterior wall ischemia, I asked myself. So we went back to the lab. Look at the ostium of the LAD. How can this be explained? Well, because the stent that was protruding into the left main now has fenestrations, overgrowth of tissue obstructing the ostium of the LAD. So that's the consequence. That's the consequence of nailing, long-term consequence of nailing the ostium. So how do you get out of this problem? Well, with imaging. I passed the wire, and then I passed the OCT probe, and you can see in the E graph, we don't have time to go into details, but this is the key information. I wanted once again to know where my wire is in relation to the stent. So look at the big green arrow. This is a pullback from LAD. Look how tight that is. So I am behind the stent struts, the protruding stent struts from the circumflex. So what technique can I do now? DK crush. And then you see the steps of the DK crush, followed by the final OCT evaluation and the 3D reconstruction. What I did not do, appreciate the neocarina with tissue on the 3D deconstruction. I still have 1 millimeter or 2 of tissue-covered stent struts as a neocarina. The only thing I could do is make it central. And you see the K image, that's the corresponding cross-section image. I do now have large ostial diameters, large ostial areas of both circumflex and LAD, which is good. It means a central carina, but I cannot make it go away. It's tissue and it's metal. So in conclusion, when you ask me how to do image-guided bifurcation PCI, it's all the steps. However, there are 2 particularly specific stents for bifurcation, steps for bifurcation PCI. And that is assessing plaque distribution. As Professor Guagliumi said, in the longitudinal images, this is particularly important. And then assess the stent wire interaction. Never forget the October trial. It's not about two stents. It's about whenever you attempt rewiring, getting with the wire again across your already implanted stents, that the imaging may be of huge benefit. Thank you very much.
Thank you very much for this excellent review on how to do things. I would say, to me, the clear message is most of the times the disease from the ostium of the LAD goes to the left main. Yeah. Although, you know, we all have the tend to say, okay, I'll fix it just putting the stent in the ostial. No, do imaging, make sure this is not happening. And I would say same with the circumflex, less often, but still, you know, this is very important. One poor man's checking is when you have the stent inflated, with the balloon inflated, you can at least, you know, do an injection and see if you keep flow in the main vessel. This is a poor, you know, imaging, obviously you have to do then IVUS, but I think these messages are very important. And of course, you know, abdominal wiring is very important, and I think, I mean, excellent. I don't know if you have make any comments on that, but I think it's...
No comments due to the delay. We are trying to catch some time. Grigoris.